So, as you know, the endocrine system describes the system of hormones, the chemical messengers that circulate in the blood from an endocrine gland to a target cell or a target tissue. And when an endocrine hormone reaches a target cell or a target tissue, it will bind with receptors in that target cell or target tissue, and it will bring about a physiological change in this target tissue. There will be some change. And what we want, of course, is just the right amount of physiological change. We don't want too much physiological change, and we don't want not enough physiological change. We want just the right amount. And to get just the right amount of physiological change, the target cell or the target tissue must be stimulated by just the right amount of endocrine hormone. That means the amount of endocrine hormone in the blood needs to be very finely homeostatically regulated, so we get just the right amount of physiological change. If there's too much of a hormone, then we can get too much physiological change. Not enough of a hormone, not enough physiological change. So there can be a hyper or a hypo situation. And both of these are abnormal. So endocrine system disorders is talking about hyper hormonal states and hypo hormonal states. So let's look at some of the effects now that we'll get as a result of too much or not enough of some particular endocrine hormones. Well, I'm pleased to say that the young ladies in the left-hand photograph, when they were children and adolescents, they had just the right amount of the human growth hormone in their blood. This hormone stimulates the growth particularly of the long bones, and it's produced in the anterior part of the pituitary gland, in the adenohypophysis. And they produced just the right amount, so they grew to an appropriate height. And it's the same with the police officer in white on the photograph on the right. His anterior pituitary produced just the right amount of human growth hormone. But for the very tall gentleman we can see in both of these pictures, throughout childhood and their adolescence, their anterior pituitary glands produced too much growth hormone. That caused too much stimulation of the epiphyseal growth plates in their long bones, and they grew excessively, causing giantism. So giantism is caused by hypersecretion of growth hormone during childhood and adolescence from the anterior lobe of the pituitary gland. Now, in both of these photos, we can see gentlemen who are very short in stature, and this was because during their growth and development, the anterior lobes of their pituitary glands did not produce enough human growth hormone. Therefore, there was not enough stimulation of the epiphyseal growth plates in their long bones. Therefore, their bones did not grow properly. So dwarfism, when people are very short in stature, is caused by hyposecretion of the growth hormone. Not enough human growth hormone produced by the adenohypophysis in growth and development. So we note that lack of growth hormone can lead to dwarfism. Excess amounts of growth hormone can lead to giantism. But what happens after the epiphyseal growth plates have sealed if someone is still producing too much growth hormone? Because we know that after the growth plates have closed over, after they've ossified, the bones don't increase in length anymore. So what happens if there's too much growth hormone after a person's reached maturity? Well, this condition is called acromegaly. Now, as you probably know, megaly means big. So you might have heard of a cardiomegaly, an enlarged heart, a hepatomegaly, an enlarged liver, a splenomegaly, an enlarged spleen. Well, let's now look at this condition called acromegaly, caused by hyper, that is excessive secretion of growth hormone in adulthood. So here we see two effects of increased secretion of growth hormone in adulthood. In other words, two clinical features of acromegaly. In the picture on the left, we notice the thickened eyebrows caused by bony thickening. And on the right, we notice an enlarged hand in a patient with acromegaly. Now, the hand next to it is from someone who does not have acromegaly, but is of a similar size to the enlarged hand that we see on the right. And the patient with enlarged hands in the right-hand photo also had enlarged feet as well. So in the top photograph, we can see a gentleman with enlarged eyebrow ridges and an enlarged mandible. The lower jaw has carried on growing. And we notice this in another patient in the bottom photo. So we can see the gaps between the top teeth are normal, but the mandible has carried on growing under the influence of human growth hormone. And the mandible has grown, and as the bone has grown, it's moved the teeth further apart. So the gaps that we see in the teeth in this bottom photograph are caused by excess growth of the mandible, caused by excess stimulation with human growth hormone in adult life. These are all clinical features of acromegaly. So hypothyroidism simply means a deficiency of thyroid hormone in the blood. For some reason, the thyroid gland is not producing enough thyroid hormone. In the Western world, the most common cause is actually an autoimmune disease, where the body's own immune system is attacking the tissues of the thyroid gland, progressively destroying the tissues of the thyroid gland, meaning that there is not enough viable tissue present to make enough thyroid hormone. And this is called Hashimoto's disease, autoimmune thyroiditis. Globally, hypothyroidism is caused by iodine deficiency. Iodine is absolutely essential for the thyroid hormone molecule. You cannot make any form of thyroxine without iodine. And in many parts of the world, there's not enough iodine, so these people cannot make enough thyroid hormone. Therefore, they start suffering from the clinical features of hypothyroidism. Well, here we see a common feature of thyroid disease. This is a goiter. Now, a goiter simply describes an enlargement of the thyroid gland, and this can be seen as a swelling in the front of the neck. And goiter may be a clinical feature of hypothyroidism or hyperthyroidism. Now, globally, by far and away the most common cause of goiter is iodine deficiency. If there's not enough iodine in the blood, the thyroid gland will swell to try and extract more iodine from the blood. But there again, goiter can be a feature of Graves' disease, which is a cause of hyperthyroidism. Or goiter can be a feature of Hashimoto thyroiditis, which is a cause of hypothyroidism. So goiter simply means the swelling. We then need to think about what is causing that swelling. Now, if a goiter is associated with hyperthyroidism, we call that a toxic goiter. The idea there is it's making toxic levels or toxic volumes of thyroid hormone. But many goiters are non-toxic. That is, they're not associated with the features of hyperthyroidism. And a non-toxic goiter, which is not associated with inflammation or neoplasm, is termed a simple goiter. And simple goiters can be seen quite often, especially in women. And simple goiters are much more common in women than they are in men. In areas of iodine deficiency, the simple goiter can often be associated with just that, with the iodine deficiency, and it will resolve if there's enough iodine in the diet or enough iodine introduced into the diet. So Dr. Hashimoto was Japanese, and I think he was actually working in Germany when he discovered that this inflammatory disease of the thyroid gland is a cause of hypothyroidism. And today we know that it's one of the autoimmune thyroid diseases. And it's caused by destruction of thyroid cells by cell and antibody mediated immune processes. In other words, the body's own immune system is attacking the thyroid tissues. It's an autoimmune process. It's a pathological mistake. It's like a friendly fire situation where the body's immune system is accidentally destroying the body's own tissues. And in Western countries, Hashimoto's thyroiditis is the most common cause of hypothyroidism. Globally, the most common cause of hypothyroidism remains simple iodine deficiency. So in many parts of the world, it's not a disease process, it's just iodine deficiency. But in Western countries, hypothyroidism, most commonly caused by Hashimoto's autoimmune thyroiditis. So this lady's just been to the hospital to seek medical help. We can clearly see that there is swelling of the thyroid gland, and we can see here that the thyroid gland is in two separate lobes on both sides of the trachea, joined by a separate isthmus. The challenge now is to work out why this lady has a goiter and to treat the underlying cause of that goiter. Now, a common feature of hypothyroidism is myxoedema. A myxoedematous patient is suffering from hypothyroidism. Now, in the skin, there's a change to the matrix or ground substance which occupies the intercellular spaces in the dermis. And this ground substance is composed of proteoglycans. That means the molecules contain proteins and carbohydrates. And lack of thyroid hormone causes changes in the chemical nature of the matrix ground substance, meaning it can retain more water. And these patients develop this form of edema called myxoedema, giving rise to this puffy, boggy appearance. It's not really like a pitting edema like you might get in renal failure or heart failure or hypoproteinemia. This edema is a myxoedema caused by hypothyroidism, affecting mostly the skin. But we can see here quite pronounced clinical features really on the left of a patient with myxoedema. And here we see the same lady on the right looking much better after treatment. Again, on the left we see a patient with myxoedema, and we see the same lady on the right a few months later after simple treatment with thyroxine. Fairly dramatic change in the appearance because the myxoedema has been reduced, in fact pretty well eliminated, by giving thyroid hormone. When you give the thyroid hormone, the chemical nature of the matrix returns to normal. It retains less water, and so the myxoedema simply subsides. Here we see the same thing. The gentleman on the left with myxoedema. After treatment, the same gentleman on the right without myxoedema because of the thyroxine therapy reversing the hypothyroidism. Now, the brain must have thyroid hormone to develop. This is true in fetal life and it's true in childhood. And also normal growth of the body depends on normal amounts of thyroid hormone. So if a woman is deficient in iodine when she's pregnant, then the fetus will also suffer from iodine deficiency and therefore thyroid hormone deficiency, and the brain will not develop properly. And it's the same when children are born. For normal growth and development of the nervous system, they must have adequate amounts of iodine to produce adequate amounts of thyroid hormone. And lack of this causes pediatric hypothyroidism, what used to be called cretinism. And it's a great tragedy that children can have severe learning disabilities and inadequate growth simply because they do not have enough iodine. So think about the iodine levels in the community that you serve and make sure pregnant mums and children have enough iodine to make enough thyroid hormone. Now, these are blatant and tragic cases of pediatric hypothyroidism, but even in many Western situations, it's recently been suggested that subclinical iodine deficiency can reduce intelligent levels, or the levels of intelligence generated by the brain because of lack of iodine in fetal life and early childhood. So something to think about. Make sure that lack of iodine is not reducing the levels of intelligence in the children that you serve. Now, this child on the left was admitted with growth deficiency and lack of intelligence as a result of iodine deficiency. She was treated, and here we see the same girl as a young lady, as a teenager, and her growth had completely recovered. Her physical growth had completely recovered. But on the picture on the right, she still suffered from very significant learning disabilities, because there's a window of opportunity for the brain to develop. And as the brain's developing in fetal life, and especially in the first 1,000 days of life, that window of opportunity has to be taken at that time. There must be enough iodine to produce enough thyroid hormone at that time. And if that window of opportunity is missed, then unfortunately the brain can't recover. So even although the body recovered, the brain didn't recover, and this young lady was left with significant learning disability, and that condition unfortunately will never resolve. The opposite of hypothyroidism is hyperthyroidism, where there is too much thyroid hormone in the blood. And the most common cause of this we see in Western countries is Graves' disease. So Graves' disease, the most common, by quite a long way actually. Multinodular goiter is the next one, where there's various nodules within the thyroid gland, and these nodules will produce thyroid hormone even if they're not stimulated to do so by thyroid stimulating hormone from the pituitary gland. So we end up with too much secretion of thyroid hormone. Now, adenomas are benign neoplasms, but even though the tissue is neoplastic, in this case, because it's toxic, it is still producing toxic levels of thyroid hormone. So toxic adenoma would be a benign neoplasm within the thyroid gland, but it's still producing thyroid hormone. Thyroiditis would refer to any condition where there is inflammation of the thyroid gland. If we give patients too much iodine, that can sometimes result in too much thyroid hormone being produced. And a rare cause is that the cause is not in the thyroid gland itself, that the cause is in the pituitary gland, in the adenohypophysis, where the TSH, the thyroid stimulating hormone, is produced. And if there is a tumour resulting in overproduction of thyroid stimulating hormone, then that will also stimulate the thyroid gland to produce too much thyroid hormone, although the site of the pathology there is in the pituitary gland, and the thyroid gland is merely responding to the increased levels of thyroid stimulating hormone. So, as we've said, the most common cause of hyperthyroidism is Graves' disease, named after Robert Graves, who identified this way back in about 1830. And we now know this is an autoimmune disease characterized by hyperthyroidism, and we now know it's caused by circulating agonistic antibodies. Now, you probably remember an antagonist works against something, an agonist works for something. And in this case, the antibodies mimic the action of thyroid stimulating hormone. Therefore, they agonize, that is, they work in the same way as TSH would do. They agonize the TSH receptors in the thyroid gland itself, causing increased production of thyroid hormone. This slide explains the pathophysiology involved in Graves' disease, and we see that a B lymphocyte is producing abnormal antibodies. Now, of course, B lymphocytes are supposed to produce antibodies, but they're supposed to produce antibodies that attack foreign material such as bacteria or viruses. They're supposed to produce antibodies which attack antigens. But in this case, the B lymphocytes are producing abnormal antibodies. And these abnormal antibodies are just the right shape to fit into the TSH receptors on the thyroid producing cells. So normally, of course, the TSH receptor fits onto the thyroid producing cell and tells it to produce just the right amount of thyroid hormone. But now, because this B lymphocyte, for autoimmune reasons, has produced lots of abnormal antibodies, there's excessive production of the thyroid producing cell. Because the abnormal antibodies produced by the B lymphocyte agonize the TSH receptor, therefore they stimulate it, they're mimicking the activity of TSH. And as a result of this, the thyroid gland is producing increased volumes of thyroid hormone. So the amount of thyroid hormone in the blood goes up. The thyroid hormone circulates in the blood, and the thyroid hormone fits into receptor sites on target cells and stimulates those target cells with thyroid hormone much more than they should be stimulated. So as a result, the patient becomes thyrotoxic. They are hyperthyroid. They are suffering from hyperthyroidism. This lady is showing the classic triad of features that occur in Graves' disease. Firstly, she's got hyperthyroidism, so she's thyrotoxic. She's got the features of thyrotoxicosis. Next, when we look at her neck, we see a diffuse goitre. There's a diffuse swelling in her neck caused by the swelling of the thyroid gland. And the third feature we see in Graves' disease is exophthalmos. Exophthalmos is the protrusion of the eyeballs, characteristic of Graves' disease. This young lady also has clinical features of thyrotoxicosis. She has a diffuse swelling of the thyroid gland, she has a goitre, and I think you can see she has a degree of developing exophthalmos. So given that she's got the thyrotoxicosis, the exophthalmos and the goitre, this is another case of Graves' disease. Well, this slide is a diffuse thyroid hyperplasia. You can identify the larynx on top, and you can probably see the rings of cartilage in the trachea below. And the thyroid gland is enlarged all over. The central isthmus is enlarged, and the two lobes of the thyroid gland are also enlarged. Now, a hyperplasia means an increase in the number of cells present. So the thyroid gland is enlarged because there's more cells than there used to be. And this gross pathological appearance would be consistent with iodine deficiency, and it would also be consistent with the goitre which occurs in Graves' disease. So this lady has bilateral exophthalmos, and I think you can probably also see there's some periorbital swelling around about the orbits of the eyes. And this is actually due to retrobulbar fat prolapsing into the eyelids. So there's been an increase in the amount of fat behind the eyeballs, and that's prolapsed into the eyelids as well, causing the swelling you can see. And of course, the increased amount of fat behind the eyeballs is contributing to the exophthalmic type appearance as the eyeballs are pushed out. Now, below we can see transverse CT, computerized tomography, of the orbits, and this is showing enlarged extraocular muscles. So the external eye muscles are enlarged. And actually, where the arrow is pointing, the extraocular muscles are so enlarged, in this case there was actually some compression of the optic nerve, causing reduced visual acuity on that side. Here we see a close-up picture of a patient with exophthalmos. The accumulation of fat behind the eyeball and the increase in size of the extraocular muscles has pushed the eyeball forward, giving this protruding type appearance. This was in combination with the clinical features of thyrotoxicosis and goitre, therefore constitutes a case of Graves' disease. This lady developed a benign thyroid adenoma over many years, and it expanded into the huge goitre that you can see in this picture. Fortunately, it was non-secretory, so she wasn't thyrotoxic. So a huge benign thyroid adenoma. And you'll be delighted to learn that this lady was treated by a highly skilled local surgeon. The adenoma was removed in its entirety, and she was completely cured. Now, it's also possible to get malignant tumours of the thyroid gland, of course. And here we see a case of thyroid adenocarcinoma. The swelling in the front of the thyroid gland, and we can also see a metastatic mass on the right-hand side of the neck. Now, whereas the benign tumour felt rounded, fairly smooth, and relatively soft, these malignant tumours felt irregular and they felt very hard. And they were also relatively well fixed in the local tissues. So adenocarcinoma of the thyroid. Now, while this lady didn't have access to surgical treatment, she was being treated by a highly experienced local physician with herbal concoctions and did appear to be responding to treatment. Well, the adrenal glands are located above the kidneys, and in fact the old-fashioned name for the adrenal glands is the suprarenal glands, the glands which are above the kidneys. And you probably remember that the adrenal gland is in two main layers. The adrenal cortex is the outer layer, and the adrenal medulla is the inner layer. And the first layer we want to consider is the adrenal cortex, the outer layer. Now, if the adrenal cortex is overactive and secreting too many adrenocortical hormones, then that is called Cushing's disease. So Cushing's disease is a hypersecretion, increased secretion of adrenocortical hormones. And the name associated with the converse condition, Addison's disease. Addison's disease is where there is not enough secretion of adrenal cortical hormones. So Addison's disease is adrenocortical insufficiency. So remember, Cushing's is too much, Addison's is not enough adrenocortical hormones. Cushing's syndrome describes a constellation of possible clinical features, but they're all caused by prolonged exposure of the body tissues to elevated levels of glucocorticoids, such as cortisol. So there's an increased secretion of adrenal cortical hormones. Now, occasionally this can be caused by a disorder of the adrenal cortex itself, but in the pure form of Cushing's disease, actually the pituitary gland is producing too much adrenocorticotropic hormone. And it's the increased levels of the adrenocorticotropic hormone from the adenohypophysis that are stimulating the adrenal cortex to produce too many glucocorticoids. Now we notice that Cushing's syndrome can be caused by endogenous or exogenous glucocorticoids. Now, endogenous means it arises from within the individual. So for some reason, the adrenal gland is producing too much glucocorticoid. Exogenous, on the other hand, would mean that it comes from outside the individual. This means that the individual has been given glucocorticoids as a drug. Now, if you want to reduce inflammation, there's nothing better for reducing inflammation than steroids. And steroids are glucocorticoid type drugs. So you might have given a patient hydrocortisone or methylprednisolone or prednisolone tablets. These are steroids. They are glucocorticoid type preparations. And when we put those into an individual, they are an exogenous source of glucocorticoid type molecules, and in excess, over a period of time, they can also give rise to a Cushing type syndrome. Now, the features of Cushing syndrome are essentially the same, whether that's caused by a Cushing's disease or whether we are observing these things as the side effects of steroid therapy. And the first three are related to redistribution of body fats. Fat is stored in the back, giving rise to a buffalo type hump. There's often a very heavy trunk, and the arms and legs become thin. And there's a rounded moon face. But as well as this, very often the blood sugar goes up, there's a hyperglycemia. In fact, this is a differential diagnosis for diabetes, because sometimes when you take the patient's blood sugar levels, it's really remarkably high. And you think, oh, this patient's got diabetes, when in actual fact, it can be a side effect of the corticosteroid medications. General muscular weakness, osteoporosis caused by demineralization of the bones, and sometimes there can be mental changes, even psychosis. Increased blood pressure and edema, also possible side effects of steroids, or indeed possible clinical features of Cushing's disease. Increased amounts of adrenocortical hormones in the blood, whether that's caused by a Cushing's disease or whether that's caused as a side effect of steroid medications, the increased levels of hormones will redistribute body fat, particularly increasing the amount of fat in the face, on the back, and around the abdomen. So more fat is stored in the subcutaneous tissues of the face, giving rise to this fat moon face type appearance, classical Cushingoid feature, the moon face. Here we see a clear example of the redistribution of body fat to the face, causing this moon face. This is the same lady before she was diagnosed with Cushing's disease, and 6 months later, after she'd had Cushing's disease for several months. You can clearly see the moon face in the right-hand photograph. In Cushing's syndrome, the skin becomes thinner and weaker, and as the abdomen expands because of the accumulation of the central fat, that's going to stretch the already thin, weakened skin. That actually causes a degree of hemorrhage, leading to these abdominal striations. And the glucocortical hormones will also increase protein breakdown, causing the arms and legs to become thinner. So what you kind of get, it's sometimes called a potato man. There's a big central mass in the middle with like little matchstick legs sticking in and matchstick arms, because the center becomes fat and the arms and legs become thin. This young lady has Cushing's syndrome. We can see the fatty central abdomen, and we can see the striations on the abdominal wall. So for those of you who aren't very familiar with buffalo, we can see that on the back of this buffalo there's a large hump caused by the accumulation of fat, because that's where buffaloes store fat. As would be expected, buffaloes have a buffalo hump. This lady's been on steroid therapy for some weeks, and she's developing the buffalo hump caused by increased deposition of fat onto her back. Well, here we see a more extreme example of a buffalo hump, but it's still caused by the deposition of fat under the influence of increased amounts of adrenocortical hormones. Addison's disease, it's usually insidious, but usually progressive hypofunctioning of the adrenal cortex. So there's not enough adrenocortical hormones being produced. And this can usually be diagnosed by finding elevated plasma levels of the adrenocorticotrophic hormone. So the ACTH is released from the adenohypophysis to try and stimulate the adrenal cortex to produce more adrenocortical hormones. So you'll find low levels of adrenocortical hormones, but high levels of ACTH. Now, the most common cause of Addison's disease these days, certainly in the Western world, is autoimmune. There is autoimmune processes damaging progressively the adrenal cortex. But sometimes it is a secondary condition. There can be destruction of the glandular tissue from tuberculosis or tumour, or maybe an inflammatory process. But most commonly it's autoimmune. Now, when Thomas Addison first identified this, most of his patients were actually suffering from tuberculosis. And this is still true in some parts of the world where tuberculosis is highly prevalent. So there's destruction or dysfunction of the entire adrenal cortex. It's not just part of it. And of course, the adrenal cortex produces the glucocorticoids and the mineralocorticoids. So there's deficiency of the glucocorticoids like hydrocortisone and corticosterone, and the mineralocorticoids such as aldosterone. And it's interesting, the clinical features of Addison's disease don't develop until about 90% or more of both of the adrenal cortices are inhibited or dysfunctional or destroyed. Similar to the situation with type 1 diabetes, really. You don't get the clinical features of type 1 diabetes until 80 or 90% of the beta cells in the pancreas are destroyed. And it's a similar situation with Addison's disease. This means that really we've got about 9-10 times more beta cells, or 9 or 10 times more adrenal cortical function than we need in health. There's a great reserve capacity built in. But what it means clinically is by the time someone presents with the clinical features of Addison's disease, the pathology in the adrenal cortices is already relatively advanced. Here we see hyperpigmentation of the gums in a case of Addison's disease. Well, in the top picture we see increased pigmentation in the hands. And in the bottom picture, even though this person does have dark coloured skin, I think you can see the streaks of increased pigmentation in the area of the big toes, for example. We're now thinking about disorders of the adrenal medulla, the inside part of the adrenal gland. And it's the adrenal medulla that produces the catecholamines, that is adrenaline and noradrenaline, also called epinephrine and norepinephrine. And a pheochromocytoma is a catecholamine secreting tumour, and it occurs most commonly in the adrenal medulla. And the main effect is it causes paroxysmal or persistent hypertension. Persistent means the hypertension is there all the time. Paroxysmal means it just occurs from time to time. So the patient might be sitting there feeling okay, then all of a sudden they become anxious, they become sweaty, they become severely hypertensive because there's been a spurt of catecholamines injected into the blood, as it were, from this pheochromocytoma. These patients need some blood work to measure the catecholamine products in the blood or urine, and they normally have imaging, CT or MRI, that will localise the tumour. Very often it can be removed surgically, curing the problem. Other times you might need some palliative medication to reduce the blood pressure. But the increase in blood pressure, whether it's persistent or paroxysmal, is so high that it becomes acutely life-threatening, making this a medical emergency. I think on this scan we can clearly see the large left adrenal pheochromocytoma, the tumour in the left adrenal medulla.